Hello, and thank you for joining us for the 49th Annual AAKP National Patient Meeting. I hope everyone's been enjoying today's sessions. I'm Diana Clynes, Executive Director of the AAKP. I am proud to help lead an organization that represents those who have chosen to raise their voice in support of greater care choice and innovation in kidney care. And as someone who has a personal connection to kidney disease through a loved one who has since passed, I join in the voices demanding a change to status quo kidney medicine and increased patient care choice without any barriers to all available treatment options. One of those treatments that will be highlighted during this session is new innovation in infection prevention, which is very timely considering September is also National Sepsis Awareness Month, and just around the corner in October is International Infection Prevention Week. These observances aim to raise awareness of the importance of infection prevention and the role that everyone plays in it. In June of this year, during National Safety Month, AAKP rolled out a new year-long safety awareness and public education campaign titled Every Patient Safe. This multifaceted campaign focuses on the unique risks and unmet safety needs of America's highly vulnerable kidney patients and kidney transplant recipients. Those risks include ongoing susceptibility to serious COVID infection and premature death, increased vulnerability to healthcare-acquired infections, and catheter-related bloodstream infections among hemodialysis patients, future pandemics, and disruptions caused by natural and unnatural disasters. Today's session will focus on one of these campaign components, infection prevention, specifically catheter-related bloodstream infections, which significantly impact individuals receiving hemodialysis treatment through a central venous catheter. But through research and innovation, the first FDA-approved catheter lock solution proven to reduce incidence of catheter-related bloodstream infections by 71% has been created. Throughout this session, titled We Are Listening, the Role of Patient Consumers in Innovation, you will learn how innovators at CorMedix identified this devastating unmet patient need, and with hard work, dedication, and substantive patient engagement throughout the research and development process, along with the power of the patient voice, this product came to market. I'd like to introduce our speakers, Ms. Liz Hurlburt and Ms. Amy Kozsuch. Ms. Hurlburt is Executive Vice President and Chief Clinical Strategy and Operations Officer for CorMedix. She is a highly engaged strategic leader in the pharmaceutical space with 20 years of experience across both academic research and industry settings. Liz's focus has been building highly engaged teams to execute clinical programs to bring innovative drugs to market as efficiently as possible. Joining her is Ms. Amy Kozsuch, Chief Executive Officer of Central Florida Kidney Centers. Ms. Kozsuch is a seasoned professional in kidney care, boasting over 2 decades of experience in the field. Her extensive background spans across clinical practice, healthcare administration, and patient education. Amy is known for her commitment to improving patient outcomes through innovative treatment approaches and her dedication to educating both patients and healthcare professionals about kidney health. We are honored to have them both with us today, and I turn it over to Liz.
Thanks, Diana. Thank you. I'd like to start today by telling you a story during our time together. And this is about one of the first dialysis patients I had the pleasure of being part of the care team for. Let's call her Pam. Pam was a single mother of 3 beautiful children who she loved to tell me stories about when I saw her for shifts on Monday. Pam had come to Rhode Island, where I had started working in dialysis from Jamaica nearly 20 years before to pursue her career in nursing. But before she finished her degree, she had to quit to take care of her ailing father. And after he passed, Pam focused solely on raising her children, and she worked as a certified nursing assistant, as well as another job at a local nursing home. And she used to share with me how much she loved picking out character scrubs with Snoopy or Mickey Mouse because her older patients really got a kick out of this, and she was so invested in them. And she said, they cost more money and I don't really have the money, but they make my patients smile, and so I'm gonna do it. And no one else is really trying to make them smile. So she kind of took that on as her cross to bear. So fast forward for a few years, and Pam, who was working 2 jobs taking care of others, started to not feel well. She had diabetes, she took her insulin reliably, and she had a few other issues too, a little bit of cardiac disease, some high blood pressure, high cholesterol, right? And she was getting more and more tired. Sometimes she was nauseous, sometimes she was vomiting. Her legs became puffy, and she knew something was off. She knew enough clinically that something wasn't right. And one night when she came home from work, she got terribly nauseous, terribly weak, and really began vomiting uncontrollably. And her eldest daughter, who was 17 at the time, begged her to go to the hospital. And a few hours after arriving at the ED, her doctor came in and told her that her kidneys were failing and she needed to immediately start dialysis. And they admitted her to the hospital. They placed a temporary catheter in her neck and began to dialyze her immediately. And a few days into her hospitalization, they transitioned her to a permanent catheter, and she found a chair at a local outpatient dialysis unit, which is where I met her. And Pam's head was spinning from all of this, right? How had that happened? Who was gonna pay for the dialysis? How would she be able to work and support her children? Was this gonna happen to her children? Could this have been prevented, right? There were all of these questions sort of swirling around in her mind. And 7 weeks after her crash into dialysis, Pam was dialyzing at one of the units that I worked in, and she got a fever. And because she was in a research study that I was overseeing, the dialysis nurse manager had called me to let me know, and I had to start documenting everything that had happened. We have a saying in research that if it's not documented, it didn't happen. So we document everything, right? So she had a lot of symptoms. Her blood pressure was really low, she was weak, she felt terribly fatigued, and the dialysis nurse took some blood cultures, which are blood tests that measure if you've got bacteria or other organisms in your blood, and those can potentially cause a bloodstream infection. And they immediately sent Pam back to the hospital where she had just crashed into dialysis 7 weeks prior. And while the doctors waited for Pam's blood culture results to come in, she became more and more sick. She got transferred to the intensive care unit. Her young children were not allowed to visit her because she was in the ICU, and she drifted in and out of consciousness for a few days until the right antibiotics kicked in to treat her infection that had really ravaged her very weakened body. And a few days later, the doctor explained to her that her dialysis catheter, which she needed to keep her alive and to dialyze, was the source of her infection. And that bacteria had entered her bloodstream where it was affecting a number of her organs. And Pam found herself very angry for not knowing. How could this happen? Nobody told her this was a risk of the catheter that she had. Nobody told her that she might not know that this infection was brewing inside her. And she was very angry with herself for not being smart enough to know that this was even a possibility. Here was somebody who was studying to become a nurse, and she herself did not recognize the signs until it happened very late. It was immediate. She was in the chair, she got a fever, she got weak, and it all happened very quickly. So she felt very vulnerable that this could happen to her again. And she was already struggling with some depression in the last few months because she couldn't work the same way she had been able to work before. She had an incredibly disruptive dialysis schedule where she was a first shift patient who couldn't get her kids on the bus anymore. She couldn't get transportation reliably there. And one of her biggest challenges was most of the foods that she had grown up eating in Jamaica and that she loved cooking for her family, she couldn't eat anymore. And nobody told her that all of these things were going to happen. So Pam had a catheter-related bloodstream infection, or a CRBSI, while in the hands of what I would consider excellent dialysis care, right? She had very dedicated nurses, fantastic PCTs that used rigorous infection prevention methods to care for her and her catheter. The catheter was placed correctly, she was dialyzed immediately, everything was done right? They scrubbed the hub, they wore new gloves, they inspected the parts of the line that they could and made sure she didn't have an exit site infection. Her clinicians did everything they could to take care of her, and that was with what they had available to them at the time, and yet this still happened to Pam and her family. And that is a story from 20 years ago when I came into the dialysis space. And every day we continue to hear those stories because not much has changed when it comes to this. So that terribly painful and exhausting experience for Pam and her family happened here in the US in arguably the best healthcare system in the world with some of the best professionals that we have taking care of patients. So the second story that I want to talk about is one that is going on now, and that is you and as a patient. Here you are as patient advocates, patient consumers, informed, truth-seeking, patient-centered care ambassadors, right, to the collective. And many of you likely started your journey on dialysis on a catheter and may still have a catheter. And that may have been your choice for a variety of reasons, or that may be the only option that your clinician had at the time to keep you safe and alive. So for some patients, dialyzing on a CVC is in fact the best choice for them. In mainstream terms, it is not what we call ideal access, right? But we have learned that ideal for you may not be ideal for you, may not be ideal for you. And you may not be a good candidate for a fistula or a graft or immediately eligible to have a kidney transplant or at the right time in your life for peritoneal dialysis. And so a catheter may have been placed to save your life. And I believe the choice to put one in your body was not taken lightly by your care team and likely not taken lightly by you. But I now want to talk about your part in this story. And with that, I'd like to invite Amy into the conversation. Amy is a nurse, a dialysis patient advocate, a healthcare leader and administrator in the kidney space. So welcome.
Thank you.
Yes.
Good to be here.
Great. So Amy, I just shared Pam's story with these folks, and I'm sure it's one you are all too familiar with. And my goal in sharing this story is to raise awareness around catheter-related bloodstream infections and to empower patient advocates and patient consumers and their families to know how to better protect themselves. In my experience, many patients that have or have had a catheter don't even realize all of what having one as their dialysis access means. You've been in the dialysis space for a long time, most currently as the CEO of Central Florida Kidney Centers. Can you share what you and your organization do to educate patients on infection prevention and particularly those that are using CVCs as their dialysis access?
Yeah, and first I want to say thank all of you for being here and looking out for yourselves and helping your fellow patients have a voice as well. She mentioned that I'm a nurse, but I am a patient advocate first. So at Central Florida Kidney Centers, and really at all dialysis centers, it's really the care team's aim to keep our patients safe and healthy and infection-free. She tells this story about Pam and how Pam did not know a lot of what was coming to her and with the catheter and her entire journey into kidney disease. All of our patients, well, not all of our patients, but the majority of our patients are in the same place. They also, have family members as well that don't understand. And so at Central Florida Kidney, we try to make it not just about talking to the patient, but also talking to their family members, their caregivers, helping them to understand exactly where the catheter is placed, how that affects their bloodstream or how it can enter into their bloodstream, and the things that they can do to help their loved ones keep keep them free from infection. So we do the typical things. We talked a little bit about scrub the hub and keeping the dressing dry and all of that. But it's also understanding that in Florida we live in this heat, to help them understand that when they sweat, that helps to speed up infection as well. We talked to them a little bit about making sure that they keep their dressing on, and always make sure that they let others know that they have a catheter if they're in a care center, and also just to help them to understand the importance of keeping that clean and safe. But truly what we do is we approach it as a interdisciplinary team. So the social workers, the dietitians, the PCTs, the nurses, the physicians are all delivering that same message to the patients.
Thanks. Can you share with the patients why infection prevention is so important, right? We harp on it a lot, we talk about it a lot, but particularly for dialysis patients, whether they have a catheter or not, but really why it's such an overarching theme in keeping patients safe.
Yeah, well, as kidney patients, that your immune systems are depleted, and infection, even the slightest infection, can be deadly. So, making sure that you stay infection-free is really one of your main jobs, and understanding that even with flu, with colds, with any kind of bacteria, any kind of virus, it's important that you identify those symptoms, you share those symptoms, you talk to your healthcare givers to let them know that you're just not feeling right, because even that slightest symptom can be an early detection for a greater infection, so that we're able to help you more quickly.
Thank you. So one of the reasons I was invited here today to talk about infection prevention is because I've had the privilege of leading the clinical efforts at an emerging biotech organization called CorMedix. CorMedix has run the largest to date study in the United States studying our novel compound, DefenCath, which is a combination of taurolidine and heparin, to reduce the risk of CRBSI in adult patients receiving chronic hemodialysis via a CVC. So through about 3 years, we ran an 800-patient study throughout 150 outpatient dialysis centers in the US and Puerto Rico, comparing DefenCath to heparin. So heparin, I'm sure you guys know, is standard of care for the catheter. It comes with every catheter that it gets instilled at the end of your dialysis session to keep the line patent or free from clots so that dialysis can flow freely. So patients were randomized in the study, like the flip of a coin, to receive either DefenCath or heparin, and we followed them until they either got an infection or their fistula matured or a number of other smaller events that would terminate them from the study. Hopefully they were getting a transplant or the fistula matured. And at the end of the study, the patients in the DefenCath group had a 71% reduction in their risk of getting a catheter-related bloodstream infection versus those in the heparin group. And we found this very encouraging and moved forward with submitting those study results to the FDA in hopes of having DefenCath approved. Of course, DefenCath is not for every patient, and patient safety is the priority in choosing access as well as choosing any drug. So patients that are allergic to heparin or citrate or taurolidine or pork products are not candidates to receive DefenCath, or those that have had something called heparin-induced thrombocytopenia, or HIT, should also not be administered DefenCath. And while DefenCath doesn't go into your body, it sits and it dwells in the lumens of your catheter, we still want to make sure patients know if it's a safe choice for them or not. So in November of 2023, DefenCath did receive approval from the FDA to market DefenCath within the dialysis community to those patients that it is safe and specifically indicated for. And since then, we have been working very closely with many dialysis organizations like CFKC, who are interested in offering their patients a new option in infection prevention for catheter care. Amy's organization, Central Florida Kidney Centers, adopted DefenCath for many of their HD-CVC patients, and they're really a leader in patient-centered care. So, Amy, can you share why you felt it was important to embrace innovation and adopt DefenCath, right? So much in dialysis has been in place for decades.
Right. Yes, yes. So, you know, when we talk about how do we teach our patients to prevent infection, you guys have all heard all of that again and again and again. Infection is going to come. Bacteria is going to enter into your body. So, yes, we try very hard to talk about that, but this is something I'm really excited about because DefenCath is actually, for the first time, giving us something that can truly help to stop infection. And the studies are proving the product's efficacy, and in our centers, we strive to try the new things, to bring things that are going to give our patients a better quality of life. And certainly a better quality of life is not having an infection and not being in the hospital and not becoming septic. So the reason that we have chosen to enter into this program is that we want to give our patients the best infection control that can possibly be. Beyond doing the care, beyond avoiding certain situations, swimming, all of those things, this is finally something that is truly protecting the patients from the inside out, rather than just cleansing and scrubbing the hub and doing all of that. Now you have another way to defend yourself from bacteria and from infection. And we are so excited to have DefenCath in our clinics and very excited to be a part of this so that we can eventually bring it to all of our patients with CVCs, because one of the things, and we talked about this, and I hope you don't mind that I mention it, but one of the things that makes me scream is when I hear someone refer to a catheter as a little white tube of death. How horrible is that to say, especially to patients who have no choice? That's their lifeline. So to be able to have something like DefenCath, to bring it in and to be able to help protect these patients, again, from the inside out, is really just brilliant. And we have jumped fully on board with this and really feel like it's the next thing. So.
Thank you. So I think one of the things that we do when we try to educate patients and empower patient advocates and patient consumers is give you guys tips on how to do that. And I think in a setting like this, that's fantastic. You take notes. But then when you actually get to the unit, sometimes that's a little bit of a different conversation. It's a different dynamic that's happening. So, Amy, can you share with our audience some tips you have for when they're actually in the unit, when it comes to having those conversations about infection prevention and infection control, and who to have those conversations with, what to ask, and what they should expect back?
First of all, you should never be afraid to speak up in a clinic. You should never, if you see poor hand hygiene, you see things happening that's going to affect your life, never be afraid to speak up. If you're afraid to speak up in your clinics, then you have other avenues to speak up, but that's the first thing. You have to speak up. Engage with other patients and form support groups to help you to have a voice. I guess that's the biggest thing that I would say is that you have to speak up, and you have to participate in your care and be the one to mandate that you demand that you get the care that you deserve. So if you, and typically the way infection spreads is unfortunately bad practices, right? And sometimes in our clinics, our staff gets busy, they're overloaded, they go over to one machine, they have gloves on, they come back over, they touch your machine, they may touch you. Say no. Ask them to change their gloves. Ask them to think of you first. Yeah, that's what I would say.
Thank you. Yeah, that's so helpful.
Thank you both. That was a wonderful conversation. And now I'd like to open it up for questions from the audience. We'll give you guys some time to kind of warm up with some questions because I have a couple that I would like to pose first. So first question, we understand that DefenCath is an FDA-approved catheter lock solution proven to significantly reduce the incidence of catheter-related bloodstream infections. Can you share with us what makes this innovation unique and how it differs from status quo care some patients may be receiving?
Sure. Yeah, so DefenCath, you're right. DefenCath is the first and only FDA-approved drug product to reduce the risk of CRBSI. And there have been a number of efforts, right, from institution-specific protocols to public health initiatives like CDC's Scrub the Hub that have been implemented in this vulnerable patient population. And I think it's really important to just take a minute to note and commend the providers and the institutions that have implemented anything in this vulnerable patient population. It's a lot of work, right? And so DefenCath is different in a number of ways than other devices or solutions, and it's thankfully can be easily integrated into infection prevention protocols. First, DefenCath contains taurolidine, which is a new chemical entity here in the US. It is a broad spectrum antimicrobial, so it's not an antibiotic, and heparin, right? So taurolidine in the concentration that is present in DefenCath has not shown any known resistance to bugs at this point. I'm sure everybody's heard about superbugs, and we all are looking at antimicrobial resistance when the wrong antibiotics are used or too many antibiotics are used. So this is an important part of having an antimicrobial catheter lock solution, because DefenCath is a non-antibiotic. So bringing DefenCath to patients is a responsibility that we take very seriously at CorMedix. We don't want to cause alarm, but collectively we have a responsibility to educate patients and providers on the risk of CRBSI and to educate on all of the options. So DefenCath is the only drug on the market that has shown a 71% reduction in CRBSIs when compared to standard of care heparin, and it's the only product to demonstrate its efficacy in a large-scale randomized clinical trial. So many patients may be receiving heparin, which is critical to keep the line open and free from clots, but heparin does not have any infection protection properties or antimicrobial caps that are out there that have shown, they've been shown to provide some protection for the catheter hub, but not for the entire length of the lumen. And those caps are their efficacy is very dependent on what it is mixed with, right? Whether that be citrate or heparin or saline. So from a public health standpoint and in an effort to ensure that we are really greatly improving patient safety and outcomes, we're committed to DefenCath becoming the standard of care for patients on a CVC.
And how can patients learn if this technology is an option for them at their place of treatment?
Yep, so certainly if you're dialyzing at CFKC, you can talk to Amy. But we have entered into agreements with 3 of the 4 top dialysis organizations and expect very shortly that will be 4 out of 5. And we're working very diligently with our newly signed customers to ensure that DefenCath is available to patients by the end of the year. Right, so each dialysis provider has unique plans for implementation. This is not an easy thing. It's not a flip the switch. There's a lot of work that goes into adding any drug or process or protocol to a dialysis organization. So it's important for patients to realize that as a new technology, DefenCath may not be available to everyone on day one. But we are very heartened by the position that a majority of the dialysis providers have taken when it comes to embracing a proven innovation and improving patient outcomes. So I really encourage patient consumers to ask their clinicians, work with AAKP, use the guide to talk to your clinicians about that and know how to best use your voice when it comes to patient choice.
And life-saving innovations are of tremendous interest to vulnerable kidney patients and their families. From your perspective, how important is it for patients to engage with their kidney care professionals and actively discuss all available care choices, which treatment works best for their needs?
Yeah, I think it was NBC back in the 80s, I might be dating myself, that launched the More You Know campaign. And for me, I think that's the mantra when it comes to patient advocacy. Personally, I believe that kidney care providers are a very special kind of provider, right? Unlike many other specialties, there is not a lot of glamour in kidney care. That is not why we are here, right? What there is an extremely dedicated group of people who are committed to fighting for what is assumed in other disease states. Innovation, maximum patient agency, equitable access to proven therapies, personalized healthcare. We don't have these types of conversations in oncology, in neurology, in other disease states. Right? So I think that we are fighting for equitable access and equal footing for the kidney community. An observation I've had through the years is how little voice is inherent in the dialysis patient care model, right? And I think the work that AAKP is doing is critical to driving that change. It is long overdue. And many dialysis providers are working to change the way patients engage in their own care. I think it's imperative that while dialysis may be necessary, that we shift it from something that is being done to the patient to something that is being done for the patient and with the patient, right? Autonomy and agency comes from being informed, and all of the options, right? Whether it be treatment modalities, choice of provider, choice of health plan, choice of medications, that's all part of that conversation. So I encourage patient consumers to own that term, patient consumer, and really understand that you can drive the change that you are seeking and that we're all seeking in this space. So I think, like Amy said, don't be afraid to ask those questions and take the time to prepare the questions for your care team and be open and transparent about what is working for you and what is not working for you. Bring a support person as a second set of ears and communicate what is important to you, and not just what your patient rights are. You want to know those, right? But you should be actively co-creating your care plan.
Yeah,
Yep.
your human rights.
That's right.
Right?
Yep.
So you're a human first.
That's right.
You have those rights.
That's right.
And Liz had referenced a guide, and so she's aware that AAKP has, we have a lot of educational information, and we're actually going to be rolling out a conversation starter that will have some information about infection prevention and some questions that will allow the dialysis patient or their care partner to start that type of conversation with their healthcare professional. And we'll also be standing up a new infection prevention education webpage as part of our Every Patient Safe campaign that we will be hosting throughout this year. So do we have any questions from the audience? Oh, great, okay.
It's not really a question, but every patient, it's not really a question, but every patient has a right to ask the caregiver or the nurse or phlebotomist, whoever, to wash their hands and then change their gloves.
Yes.
Absolutely.
Thank you. Our next question.
Hi, I actually have two questions for you. First of all, is this device or this procedure available to those who do home hemodialysis? That's the first question.
Okay.
And the second question is this device or treatment option usable in situations other than dialysis? And the reason why I asked that question is that my son received a second kidney transplant on March the 4th. And they had a drain put in where it was, and he was only in the hospital like 3 days, and then they sent him home, but they removed the drain when they sent him home. And 2.5 weeks after that, he had to be taken by ambulance back to the hospital, where he spent the next like 15 days because he developed a sepsis infection as a result, I guess, of the fluid buildup getting into his bloodstream or the bacteria, whatever. But it was a real mess, not to mention the fact we do have a blood clot factor in our family. It's factor 2. It's a genetic blood clot factor. It's not a real serious one, but nonetheless, it's a risk. And
Sure.
I was just wondering if this particular treatment method or this would have been beneficial to us, or if they've considered using it in other modes as opposed to just dialysis. Those are my questions.
Sure. No, those are great questions, and I'm really sorry to hear that your son had to go through that. Two kidney transplant is heroic, and to have to deal with a side effect like that is really scary. Yeah, that is, I mean, sepsis is devastating for sure, no matter where it's coming from, whether it be a dialysis catheter or something like that. So to your first question, so DefenCath is indicated for adult patients receiving chronic hemodialysis, whether that be in the home setting or in center is up to the clinician. So certainly home patients are eligible to receive it. They would have to administer it themselves and be trained on doing that. But the same way that they would probably be locking themselves with heparin at home or something else at home, they could be educated to do the same. It is the identical administration as heparin. So it is instilled and aspirated the same way, whether that be by a PCT, a nurse, or the patient themselves. Right now, we are specifically limited. We received our FDA approval under something called LPAD. We're only the third drug ever in the US to receive LPAD designation, and it's a limited population of antibacterial drugs that were expedited through FDA because FDA saw that it was a public health crisis and that have fewer limited treatment options for patients. So that being said, there is certainly a need in a number of other catheters, and we are later this year launching a study in pediatric hemodialysis and also adult TPN patients for those receiving total parental nutrition through a CVC, and exploring other indications like oncology and other uses where a catheter could be in play. I mean, at the end of the day, we're not treating something, right? We're primary prevention for taking care of the CVC, regardless of why you have the CVC, but we are still working on getting data in those other indications, and then would need to submit that to FDA for further label expansion. Yep. Okay, great. Hi, Dr. Fadum.
Hi. Well, I was involved with the Tarladine Lock study, as Anthony knows. And I think it's a great product. I was the principal investigator with it. I mean, we were blinded, so we really weren't sure what was going on, but I sort of knew anyway, kind of could feel that I knew. But I just want to make a couple of points. I'm not sure what the fourth LDO is. Are you allowed to mention the name?
So no, and we're actually referring to them just as dialysis providers, because you do have some very large dialysis organizations and a number of mid-sized dialysis organizations, and thankfully lots of small dialysis
Well, there's
organizations.
DaVita, Fresenius, and US Renal. Is DaVita and Fresenius, are they using your product?
We have had we've had very good conversations with those, and they are, we're actively in conversation. I can say that multiple dialysis organizations have adopted DefenCath and in the process of rolling it out.
Good. The other thing is, I think it's important, I'm sure half the world, maybe 3/4 of the world is going to be on an Ozempic someday, and it's the same sort of thing. Mm-hmm. There is no magic pill. There is no magic lock solution that's going to prevent all problems. Right. I think it's important that we still scrub the hub and we still do all of the things that we're already doing to provide. Wash your hands. When you take your gloves off, wash your hands. Don't run around the unit with a pair of gloves on. And if you're a patient and you're well informed as a patient, like the people that come to AAKP or who read Renal Life, then tell the technician or the nurse who might be younger than your socks, say, hey, look, they say, you need to go ahead and wash your hands. Don't just come touching me by taking your gloves off and putting on another pair. I noticed you didn't wash your hands. Or you need to really scrub the hub. The second thing, which is really critical, is if a patient, I don't like catheters, period. I love fistulas. But if you have a patient with a catheter and all of a sudden their renal function returns, they have acute kidney injury, and if you have that acute kidney injury, don't just go home. say, make sure you get that catheter out. The worst thing that can happen is a patient can go home with a catheter and not do anything about it for a couple of weeks. Those are the people that are almost guaranteed to come back in with an endocarditis with a terrible valvular infection that can be super fatal. So that's just a good tip that you might want to pass on.
Yeah, no, those are great points. And I think one of the things that you mentioned and Amy mentioned, we've all talked about, is a lot of the infection prevention methods that are out there are very focused on the external, right? The majority of bacteria that is going to get into the catheter, we know starts on the skin and can migrate its way through. One of the unique aspects of DefenCath is that it works intraluminally or within the lumens of the catheter. So even when, and I wholeheartedly support, scrub the hub, all of the rigorous infection prevention methods that the nurses and PCTs are using, they're not able to get inside the lumens as the catheter is traveling down. And so I think where DefenCath is special compared to what else is out there is that it works intraluminally where you can't see an infection. So we're not talking about exit site infections. We're not talking about those where there is redness and pus coming out necessarily, right? We're talking about something that is happening underneath and deep within the lumens, in addition to those that could get introduced from something on the skin. That is correct. Yes. Yep. Yeah, there is I mean, while it has a non-specific mechanism of action, DefenCath does inhibit the adherence to cell wall, the bacterial adherence to cell walls, and to your point, that disrupts the first step in biofilm formation, and you don't know that biofilm formation is happening, right? It's not as though you could walk by or a nurse can walk by and inspect the catheter and say, oh, there's biofilm, that's going to become a bloodstream infection. If we could do that, then that would be a fantastic crystal ball, but unfortunately, we don't have that yet.
So I'm a patient, and I'm not going to try to be Debbie Downer, okay? Because what you're talking about is a good thing. But where do you have your training involved in this whole process? Is it training directly involved when you're talking to the patient about a catheter, or what? Because I have a huge concern about the training that's being done, because patients aren't getting the training that they need in numerous areas of dialysis. So now we're adding something to it. So is that going to get thrown by the wayside? And then when we're talking about a patient asking a technician to wash their hands, what are we doing when the technician doesn't like that, and all of a sudden there's retribution back on the patient, because it's happening way more than what we want to admit.
Yeah, and that's horrible, and that should not be tolerated. And the only way that it's going to change and not be tolerated is to continue to speak up. If we just don't say anything because, oh, that technician's going to come after me, that's not going to stop it, and it's going to continue on. So you need to speak to more than one person. You need to call your network. You need to raise your voice about that type of treatment, because you don't deserve it. And my centers, our team, our nurse managers will not tolerate that type of behavior of our staff towards our patients that we care for. You know, you're there to receive help and support in your treatment. You don't need to have fear along with that. So there needs to be a no tolerance policy for that. And the only way that's going to happen, and I know it doesn't happen everywhere, I know, believe me, I've worked in this industry for 35 years, and I have seen some horrific things, which has turned me into a patient advocate. But the only way that those types of people and that type of behavior are stopped is by raising your voice. And as far as like when you're talking about the training, and again, it's hard to speak to that because not all centers are the same, even within a same company. There are very excellent clinics that really engage and work with the patients and really have a lot of good education and training going, and then you have others that are in between, and then you have some that just are in and out for your treatments, and you barely have a conversation with the staff. What we try to do at Central Florida Kidney is approach it from all different angles. We don't just have one person come and speak to the patient, help them to understand a certain procedure or process or diet or insurance plan. We attack those things as a team. So you're going to hear it from more than one team member. You're going to hear it from more than one perspective, and you're going to hear it over time, not just, let me tell you about this, and then you don't hear about it again. Oh, sign here that you understand this, and you never hear it again. It's continuous.
Great. Well, thank you, everybody, and thank you, Amy and Liz. I appreciate it. I know we're a little bit over time, and I'm sure there probably are a few other questions. So, please let us know what your questions are if we didn't get to it, and we'll be happy to share it with Liz and Amy and get back to you with responses.